with our panel here. Like I mentioned, you can continue to tweet PennApps Health using our hashtag, and we have some amazing panelists. We're going to sort of switch gears from where the keynotes were, which is sort of high-level strategy and information about the health industry. And the second hour during our panel, everyone here on the panel has engineering experience and product development experience and is either working in academia or working with a big corporate firm specifically on issues related to engineering and app and software and product development. So I think for this second hour, really think about how we can sort of take some of the ideas that we learned in the first hour about sort of high-level strategy, things that you may be interested in health, and then let's kind of come together to ask questions with the panel and interact in a way that helps us better understand the technology tools that are out there and what's sort of doable over the weekend in the hackathon, and ways that you can make the most out of relationships with these amazing mentors, and partner up with other engineers who are both in this room and people who haven't gotten here yet or checking in a couple hours. You can sort of take your ideas that you have now and pull people onto your teams and introduce them to the mentors and start working with them right after the kickoff gets going later this evening. So with that, I'd like to give each of the panelists a few moments just to introduce themselves. And maybe why don't you tell us where you are now and sort of what your main projects are on the technology side. We start. Elliot's already sort of introduced himself, so maybe we'll just jump over to Brad for now.
One? Okay. So, good afternoon, everybody. My name is Brad Genereaux. By day, I am a product manager with Agfa Healthcare. I work in enterprise imaging. And so what Agfa Healthcare does is medical imaging across any of the X-ray modalities, so X-ray, ultrasound, CT, MRI, and we're involved in the moving of those images back and forth to the radiologist, to the clinicians, even to the patients in order to get the pictures out. So aside from that, my day job, I also am the DICOM Working Group 27 co-chair for web technologies. This is an international global group that works to build up medical standards for transmitting and storing of medical images. So if you, anyone, or if you've had X-ray or any other kind of images done, it is done by so it is truly, there are billions, trillions of these DICOM files. I come from the healthcare industry, so I spent 5 years at the largest hospital in Canada. I'm actually out of Waterloo, Canada. And I also spent 5 years at one of the smallest hospitals in Canada. And I've implemented pretty much every single healthcare system under the sun, from the wrist to pharmacy to lab to telephony, like to telephone systems, networking, everything in between. I do a lot of innovation. I spend a lot of time tinkering, hackery with all sorts of web libraries. Web APIs are truly my passion, so I think that's enough about pass on to.
All right. I'm Alex Roederer. I am a PhD student at the School of Engineering here at Penn in the Department of Computer and Information Science. My work is mainly in automating the statistical analysis of medical data. So I'm interested in high-frequency physiologic signals, things that are being collected right now in ICUs at HUP, at CHOP, things like heart rates and blood pressures, SpO2s, and looking at how we can take those physiologic signals and translate them into information that doctors, nurses can actually use to help treat their patients. So it's often called clinical decision support. It's building systems that analyze data. So I do a lot of work with machine learning techniques, a lot of off-the-shelf, as well as developing new algorithms for analyzing these sorts of time series signals. And I work really closely. I've been lucky enough to work really closely with a lot of different doctors and nurses in PennMed, and worked on a few different projects trying to specifically diagnose or help detect diseases like sepsis, cerebral vasospasm. I've looked at general deterioration in surgical ICU populations, lots of different problems, all having to do with this idea of looking at physiologic data. That's my shtick.
All right. Hi, I'm Andrew King. I'm also a PhD student with Alex, but my focus is trying to make sure that interoperable medical systems are safe. And the main challenge is when people are talking about an interoperable medical system, they're really talking about sort of a universal plug and play. They want to be able to plug in a bunch of medical devices to the network, for example, in a hospital, like in an IC or in the OR, and they want them to sort of just work and sort of automate some sort of therapy. Now, the challenge is when it comes to safety is you can't test all the possible combinations of medical devices people may want to use. And so my research is focusing on other ways to ensure the safety of these medical systems.
Maybe the other one too, I think. Boost volume a little bit too. Nope. Hi, my name is Damien, Leri. My background is in information technology, mainly as a consultant. I have a company called Big Yellow Star. And now I work for Penn Medicine in the Center for Healthcare Innovation, which is also where Dr. Patel is affiliated, the previous speaker. There's a couple areas, well, we work in basically all areas of the health system. Pretty much any problem that needs to be solved will help try to do sort of rapid validation of different types of solutions, for example. A couple of the projects that we're working on now, or the problem areas that we're working on. One is called Connected Health, and Dr. Patel may have talked about this already. I didn't see his talk. But between times when a patient sees a clinician, that time frame is much larger than the time that a clinician spends with a patient. So we're trying to sort of enrich in the communication and information exchange in both directions that goes on between clinicians and patients, and that's a huge challenge and something that is really going to be a difficult one to solve. One reason is patient incentives, making things interesting for a patient, making health seem something that they sort of would want to be engaged in, not something that's a downer. The app Zombies Run, I think, is a great example of an app that's a health app that actually is successful. So if someone can make the next Zombies Run, I think that would be a great success. The other area, or one other area I want to mention that we're involved in is in clinical setting. For example, within a hospital, there's a shift now to being more mobile, and so we just made a sort of mobile electronic chart, patient chart, called Connexus, which was sort of the idea was from Dr. Bill Hansen, who's here, the Chief Medical Information Officer for Penn. And that's been really successful. So that puts the patient chart in a very mobile, smartphone, platform. And then, so I'm now working on a communication system, which will take information such as what you're talking about, this decision support information from algorithms, and solve the problem of how to deliver that to the right clinicians at the right time, and in a mobile way, in a way that's convenient for them, so they don't have to go back to a computer and then look at, this patient has, is about to have sepsis, or has been, having a seizure. It really tries to target the communication. So those are two areas I'm really excited about.
My turn, last on the list. I'm Ken Russo. I'm the Director of Enterprise Architecture at Independence Blue Cross. I'm responsible for basically our member portals, our consumer and mobile programs. So we deliver basically mobile solutions and things for our members and prospects. And we're all about, basically, I hate to say it, we're a nonprofit, but nevertheless, we have to attract new members to basically pay the bills and, keep members healthy and that kind of thing. So we provide, I'll talk more about the app later if anybody, we can give you a demo even later on. We started about 2 years ago at Independence, where we did not have a mobile presence, and what we've embarked on is essentially developing basically a framework, that, delivering this on all the channels, if you will, all the digital touch points for our members so they have a consistent experience in terms of not just dealing with, customer service kinds of things, paying your bill, looking at your benefits, having your ID cards, but also having your personal health record. So providing those things so that, when they need health care, when they need things to basically keep them healthy, those are all the tools and technologies that we're looking about empowering our members with. So what we're embarking on right now is basically taking, this, what's on this device, which we re-engineered about 2 years ago, and redoing our portals so that we have a really, the idea today is called mass customization, so that a member's experience or a customer's experience is targeted just to things that they need or are useful to their life. So anyway, I've been around product development for quite a while. Previous, I was Chief Technology Officer for Unisys Financial Services, and prior to coming to IBC, I was basically in Homeland Security running some of the things I can't really talk about, but it was a lot of mobile development and, basically command and control and all the things that you see at the airports. My engineering team had a lot to do with installing all that.
As you can see in the panel, I'm going to kick off with just 2 questions from Twitter, and then we'll open it up to you. The first is talking about the accuracy.
I can speak a little bit about this. We actually been playing with this in our labs now. I think it was with a Fitbit, and we were doing some tests. And throughout the day, your Fitbit will count the number of steps you take. And I think what was it? We found it to be 1,000 steps off over the course of the day. And so the question is, well, is this relevant? Well, the problem you're trying to solve. But I think the bigger issue is right now the data that comes off the Fitbit doesn't give you any information about its accuracy. So this is just a challenge people need to deal with if they want to use that data. Hopefully, as people start building more and more of these sensors, they'll start incorporating meta information that will allow people to understand the quality of the data coming from the sensor.
In regards to, I have a lot of experience with sensors that are in ICUs even, and those are often higher quality. They're attached directly to the patient. There's someone watching the connection to make sure that it sort of is maintained, and even the data there is very noisy, and there's a lot of trouble. The sensors will give you some idea of whether or not the data that they're producing is itself accurate, but it's still often very hard to tell. And so I think mobile sensors, all sensors right now are at a point where there's a sort of been a proliferation of them in healthcare. But it's definitely still a challenge to figure out whether or not the data coming off of them is accurate. And yeah, time synchronization is a whole other issue. It doesn't exist. Yeah.
So one other thing another major problem in the hospital is time synchronization. And so we were involved in a study where we went through a number of hospitals and looked at what the clocks were set in all the different medical devices. And the skew between the various clocks, I think in the worst case, was like 32 years.
It averages something like 57 minutes?
Yeah, it averages around about an hour, but in the worst case, we saw one device that thought it was, like 1979 or something like that. So, and so someone mentioned that you could use NTP to synchronize this, but I think in practice it's been a large challenge for the healthcare providers to actually properly synchronize their medical devices.
I can add to that. As working in the hospital, there are 2 times of the year that is absolutely terrible for IT. While there's lots of times that are terrible for IT, but 2 specific times with regards to timing, and that is daylight savings time. Because what ends up happening is doctors will order tests, and then somehow the result comes before the order even came. And so timing in this case is absolutely everything. Another case where this whole synchronization is really important is things like nurse calls. So we had a system whereby from a registration, we had clerks downstairs typing in, okay, this patient is in bed 123, And then that trickled up to our nurse call system, where someone pressed the call bell, and then lights would go off, and say, and we could actually call in and say, okay, Mr. Smith, what seems to be the problem? But when these things are happening out of order, I end up transferring the patient before they've been admitted. I discharge them before they've been transferred, and these things, when they quickly fall out of order, creates chaos in some of these systems. So that whole synchronization piece and the integration between the different systems becomes really important. Yeah, absolutely.
You can also imagine like a layer, maybe as an opportunity, a layer with the data coming from these portable consumer devices needs to pass through that would help to either normalize it or sort of weed out some of the noise before it actually hits clinician eyes, or at least just extracts like the main highlights of the data, and possibly add some, through analytical means, add some some idea of how accurate it is.
Sort of related to that is another question that came in, and that's related to sort of the challenge of getting into that ecosystem, which seems like both a cultural challenge as well as a regulatory challenge. And for the engineers over the weekend, and just sort of thinking about trying to tackle interesting problems in health, how do you navigate that and find sort of fertile ground to actually build on and not just to sort of think is interesting?
Let me take that. I didn't answer the other one because we're not really into clinical, or we're not to give medical advice, any of that stuff. So have that disclaimer. But one of the things that we do a lot is, we do get test results in, from our members, and we get it, both on things that they self-record with some of these devices, and what is interesting is not so much that particular instance of the data, but the trends. It's all about data analytics. It's all about, is a pattern evolving? In our particular case, we look to avoid people going to the emergency room, where cost of care is very high. So, if we, with our nurse coaches, if we can look for trends in the data that appears, that helps us a lot. Right, so we'll get reports in from, like A1C levels that will come in from, standard provider like LabCorp or Quest, whatever, and those are usually pretty decent in terms of the quality of the data and stuff like that. But one of the things that actually does come in sometimes is they'll switch who the patient is. And they'll actually associate with the wrong patient. And that actually creates havoc in terms of, as you try and create those, they get rectified over time because it's usually human error. But sometimes we deal with a lot of partner systems. And if you can imagine all these transactions that permeate through these enterprises of all these connected systems, to have the corrections and the adjustments permeate through the whole system accurately and timely is always problematic.
If I understood the question correctly about there's a barrier to entry for people trying to get into sort of consumer sensing for health, I would probably disagree with that because of things like Apple Health Kit has created a channel into the electronic medical record, including Epic, the one that Penn uses. So all you have to do with your app is get the data into Health Kit. And granted, Health Kit only covers certain metrics. But you can, build an app, put the data into HealthKit, and that handles a lot of the hard interoperability problems. And there's a better alternative to HealthKit called openmhealth.org, which will work on Android as well, although that's more of in its infancy, so it hasn't really got connected with Epic, but that's a more open source, open standard.
Yeah, so the question is, that maybe what I'm supposed to answer is, does the regulation somehow prevent people from getting into the ecosystem? And I don't think so. I think that, so just to give an overview, in the United States, when you want to market a medical device, let's say, you have to specify the intended use of the medical device. And so if you, or your software or whatever, and so if your intended use is not to sort of replace something that a doctor already does, or it's not to manage some sort of life-critical process, you probably are not going to have much of a regulatory burden. On the other hand, if your intended use is, I'm going to run an algorithm that will sort of manage the delivery of drugs to the patient, then you probably do have a much higher regulatory burden. If I were to speculate what the biggest barrier to entry is for the ecosystem, it's probably, if you're talking about making products, it's probably the payment structure in medicine. So the thing is, if you want to sell a product to a healthcare system, let's say like Penn, you have to, basically they need to make a business choice when they buy your product, and they basically need to figure out if that product will allow them to extract more payments from the insurance company. But that's basically where all their income comes from. And so if your product, even if it's a great concept and doesn't somehow allow them to extract more payments from the payer, you're probably gonna have a hard time selling it. So that's just my sense.
Yeah, sure.
So I think we all had slightly different reads on the question. But my take on it in terms of how difficult is it, in the context of a hackathon to do something with data or hardware that is meaningful in a world where, all these systems are siloed. Long term, beyond the hackathon, you need relationships. You need to begin developing relationships with people who are willing to work with you and test it. But in the meantime, if you hustle and you're truly a hacker, you're going to find systems and proxies that let you get off the ground. When I started my company in the radiology space, I didn't have access to a PACS, a picture archiving communication system, but that didn't mean we weren't able to find open source software that emulated a PACS and quickly set that up and quickly find data sets. And you can do that today. If you want to, over the weekend, play with a PACS, download .com for Shay, and you'll have a PACS up and running in 20 minutes probably if you're fairly good hacker, and you'll find image data sets that are free and you put them in, and then you can develop whatever you want on that as an initial iteration. Is that going to be a clinical product? Of course not, but it gets you off the starting blocks, and then through relationships you'll be able to implement in real world environments later. So that's true for electronic medical records. It's true for picture archiving communication systems. There's tons of tools out there to let you do a first approximation of what it is you want to build, and that you would be able to do this weekend.
One of the questions I had was, where does big data fit into this? That was one of the questions that was sort of circulated on specific community. I know there are two open data sets, and Penn has worked really well on projects that incorporates both clinical and genomic information.
My comment would be, in general, there's tremendous opportunities around computational biology and genomics, and it is a very information-intensive environment, and with a lot of things you can do around products and hacks. But it's sort of outside my experience to know what's available. So.
There's a huge need for effective visualizations in, I experience in the hospital, so I'm going to talk about the hospital, but I think across healthcare, if you go into a hospital today, you see a lot of computer screens that look like they were made from Microsoft Access 95, which is a huge issue because you have doctors scrolling through spreadsheets with hundreds of thousands of rows looking for the most recent data value, for example, which is preposterous. They don't have time for that. One problem in particular that I haven't seen addressed that Jacqueline and I actually worked on briefly that needs to be addressed is rounding. So doctors, when in the ICU, doctors will come in the morning, meet with a team of attending physicians, nurses, clinical coordinators, and go to each patient and review that patient's status. So they need all of the information about that patient that is relevant to them at that point in time, right then, like at that point. Unfortunately, because all of these things are very siloed, what ends up happening is you have people on different computers with different bits of information, calling out numbers and reading things off of charts. There's no sort of uniform presentation interface or visualization interface that would let everybody sort of come together and see all of the information at once. And so the rounding process ends up taking hours, like 4, 5, 6 hours every day. And it's grueling. They're laughing because it's terrible. And that would be something that, like, an effective visualization, right? If you had all of the information, that's one problem. But then also delivering the right information that they need to see, the relevant information, that's critical. And if you could do that, you could speed up rounding, you could save doctors and nurses a huge amount of time, which would save people's lives. So that's one.
Yeah, I agree. I've also seen heard that need for sort of rounding or more sort of comprehensive data displays for decision support, because the data display traditionally has been sort of more from a geek perspective of, all right, let's put the vital signs over here and the medications over here, whereas clinicians really want to see how those different data points interact for a particular patient. Another problem area is population management and being able to do hotspotting of different types of patients or different subsections of patient populations, and visualizations are great for that type of thing. Even open-ended systems. I mean, some of these, the challenge is that if you're not a clinician, how do you know how to construct these, like a dashboard, like a rounding dashboard? Well, maybe the way to solve that is to make a tool to build rounding dashboards or something like that, to really empower clinicians to use visualization.
I was going to make a really quick comment. If you really are interested in going in and hacking in the hospital space, you really need to go in and shadow a doctor in the several hospitals just to sort of see how they do things, because you'll probably notice a lot of low-hanging fruit, like this.
Yeah, no, absolutely. In my world, where I've spent time in the hospital, there are so many cases of taking just a piece of information and putting them together to make some really innovative discoveries about information. So as an example, I remember going through a case costing exercise. So for a patient who came in who had stage 2 lung cancer, running them through how much does that case cost end to end until the patient is cancer free or has become deceased, and breaking out that cost depending on all sorts of different factors. So what was the medical oncologist who was treating them? What was the radiation oncologist? Is certain practice behaviors changing the way that it actually costs to treat the patient? And what was the ultimate outcomes? Another case, which was very interesting, in putting the pieces together, starting out from a family physician out in the rural area, we had done a case where a patient would come in and see their family physician. It's like, well, their blood levels are a little bit elevated, might be cause for diabetes. The specialist, which is 45 minutes away in the big city, needs to have a look at this. So the endocrinologist, etc. So they'd fill out a form, they would fax it or mail it. It would sit on a fax machine. Maybe 3 to 4 months later, someone would pick it up, book an appointment with the elderly patient, and then someone would cancel appointments. They'd have to drive in the big city. It's a big stress factor when all it really takes is, hey, this number's 75. Should I put them on this drug or not? And to streamline those processes, just putting that information together is a huge value save for everybody in terms of both cost but also in outcomes.
All right, that's down to you in a moment. I would go so far as to say, so design's a pretty big space, and if we just limit it to visual design, I think I would turn around and say visual design is broken everywhere in healthcare. It is, 89, Microsoft, whatever, Access 95, like that would be recent for some of the stuff you will see there, okay? You could spend, I would agree with the assertion, if you spend an hour in an emergency room alone just observing, it will be an eye-opening and horrifying experience for most people who are used to technology and design that's far more sophisticated. So visual design is a part of it, but the entire user experience, like in terms of UX and how that applies to healthcare, user interface of applications, the UI dimension, the industrial design of medical devices themselves. I mean, there is so much opportunity if you just immerse yourself for a short period of time. If you don't have the idea and you come from that background, you will immediately see 20 things you could fix. So it's not a great answer, but there's just so much opportunity there.
There's probably technology that lets you use one. No. But anyway, mine's always from a different slant. Okay, and in terms of visualization, there's multiple dimensions of it. Certainly from a visual interface perspective, we actually at Independent spend a lot of time in terms of providing interfaces to our users that are meaningful and easy to use. And we spend a lot of time looking at that. So even things that are done on this device as a user app, we're recording what they're doing and time spent in it. And the whole idea is not tracking on a person basis, but making it so it's easier for them to reduce the number of clicks, to basically provide information at their fingertips. One of the apps that we have, or functions on the app, is like finding a doctor or finding an urgent care center. And we look at the amount of time it's used, the other one is claims, and versus the amount of time the member is looking at the data and what to take to do that. So we spend a lot of time looking at the data, both from the visual interface perspective, but actually looking at the actual data, the analytical analysis, and you just can't look at numbers, you have to look at trends. So looking at, essentially, from looking at reams and reams of volumes of data that are in the data warehouse, that we mine in a visual interface to go look and see, well, how you put things together, how do you connect the dots? In other words, if somebody's, looking for a provider and their experience is taking longer, maybe it has to do with where they're located and the providers that are close to them, or, essentially the application that we built was too complex. But also to provide that visual interface to our members such that they see the trends, so that when we see things, that may get reported through test results, to basically raise triggers and alarms and things that, and provide it, not just in a word on the phone saying, hey, we have something you can go talk to your doctor about, but to give them information at their fingertips in a graphical, visual way that's easily to consume. You just can't give numbers. You have to give what it means and what the trends are.
Hi, I'm Dr. Ross Copel. I study this for a living. So there are a couple of factors. One, the system's DNA, the EHR's DNA, was built on billing. And so you have a transaction focus as the initial structure, which doesn't help. Two, since 2009, federal government subsidized people to buy, quote-unquote, certified EHRs and other technology. And so you had an artificial market where people were desperate to run in. Three, the cost of the software was such that there was no opportunity for buyer's remorse or for clinicians or others to complain when the system didn't work. So Penn is buying Epic for about $400 million. Cost of installation will be $1.6 to $1.7 billion with a B, because you have to train everybody connected to everything. All of the interfaces are homemade and idiosyncratic. So if you spend $1.4 billion or $1.6 billion and you've decided that it's not the ideal system, you're married to the mob. The next issue is the fragmentation of healthcare systems. So healthcare systems are made up of fiefdoms of imperious physicians and others. And so it's very hard to get agreement as to what system you want and how you want it arranged. So in essence, you're selling to not the hospital, but to a variety of individuals with supreme power. I could go on, but that's more than enough. Thank you.
Is there a question?
No.
I actually had another idea. So another specific problem I was thinking while other people were responding, something that visualization would really help with. We've talked a lot about healthcare in terms of the impact of doctors on patients and things like that. There's a whole other level of healthcare in terms of allocating those resources, putting people in rooms, putting people in beds in rooms. This is actually a major problem at HUP, and it's the reason they're building a whole new set of buildings on 37th and Market. It's because there were not enough beds. There are not enough beds in ICUs. So you get people waiting in hallways. They need to be transferred to an ICU. They're very sick, and there's no bed for them in the ICU. And you often don't know that until you've already put in the order to transfer the patient out. And they're sitting in a hallway, they're waiting. And then you lose track of them because they're not where they're supposed to be. So something that an effective visualization tool could do would be to highlight this problem is tracking where patients are and what it looks like when a hospital runs out of beds. And I think people don't realize the impact of space and resources. There are some solutions people have been working on, schedulers, automated schedulers that do better than humans can do at scheduling beds and resources. But I haven't seen that visualized in a really effective way, and I think that would be really powerful if someone could do that.
I think we had a question in the back.
Just to
Repeat the question. So health information exchanges are kind of popping up around the country, and they're designed so that the hospital systems, we've heard a lot of talk about all these different enterprise software systems within a hospital or within an insurance company, and they don't really talk to each other. So these health information exchanges have been set up to try and facilitate that. And the question was, what work has been done with these health information exchanges, and how do they sort of fit into the idea of doing something this weekend in a hackathon?
Well, I'll try and answer. IBC is involved basically in that. Basically, there's a regional one that's going on around here. There's a number of different health systems that are part of that. So IBC is part of a colleague of mine is actually a lead on that particular effort. So I can't talk the technical details about it, but it's a very simplistic way. But the main thing was getting everybody to cooperate and agree to share. The technology in terms of sharing it is actually pretty elementary under the covers. We're actually involved with the BCBSA, which is the Blue Cross Blue Shield Association, and we share information between plans because the Blues act basically as a cohesive player for across the country, if you will, for many national firms. So we share in claims information, we share outcomes, we share all kinds of clinical information. We actually have standard interchanges that we do that, but how we're doing it with third parties as well, including our members, is something called Blue Button. It's a very elementary way, but it's a way we all can commonly talk. It came from the Veterans Administration and actually didn't come from the Blues Association. It was actually on one of the screens somebody put up earlier. But that is a foundational piece. There's something called Blue Button Plus, which takes that to more of a specific, data-driven model, so to speak. But that. The issue of the exchanges is more, I think, more political and funding and how they keep ongoing funding in terms of there's like an initial investment that's required to get them going, but over time they're meant to be self-funding, and that's I know a lot of organizations, state agencies have come to the payers, if you will, saying, hey, you guys are going to be the ones to benefit the most out of this, right? So you guys should foot the bill for it. So, those are kind of things that all have to factor into the equation. So it's not really so much a technology; it's more of a political and organizational and kind of issue.
So on the technology bit, what sorts of so if you were to try and use Blue Button this weekend, what sort of technology?
Okay, so what IBC is providing, we're going to have some staff here that'll be here this evening. We're actually bringing some data along that actually we have Blue Button now on our app. It fits basically the same standard as the Veterans Administration, but we'll produce basically a clinical care report, that we're going to obfuscate. So we have some samples, we'll have some sticks that will be available this evening. Somebody named Kendall will be here this evening, and she can distribute that. But we can make that available, and that has, pretty much what we see We actually supply that to providers as well. So that's got a pretty much broad spectrum of the state of where a patient's record is. It's got medications. It's got the kind of last admissions he has. It's got allergies. It's got a whole bunch of things, and it's got an XML structure to it, the one that we'll share today.
Yeah, and to clarify this, so Blue Button data is on a patient level. It's not a population data set. Right. But I would second that. I think that's a great topic for a Codathon is how to sort of consume the Blue Button Plus data format and show that information to the patient, the user who owns that data, because all of their different healthcare providers will end up using that format, and so your app can take take various data sets all in that same format, combine them, and then create a much better user experience. Additionally, you can do a sort of a translation, not just showing the data, not just doing data visualization, but how do you convert that into the concepts that patient uses at the right time the patient wants to know about them, the language that they that they read in, or if maybe they don't read very well. There's a lot of challenges along those lines.
I'll give a little bit of a different take. So in order to connect up to the healthcare interchange tools from a standards perspective, so I'm wearing my DICOM and my IHE hats, there are a number of things to consider, but I wouldn't get hung up on over the weekend. So things, for example, authentication. So you just can't go and query the HIEs and expect to get everyone's healthcare data. So to be cognizant of how you would approach that, but I wouldn't worry about trying to solve that problem this weekend. And the other important piece is patient identity. So if, for example, at a local hospital, I've signed the patient 1, 2, 3, well, at a state level or at a national level, they're not going to be local hospital 1, 2, 3. When the patient moves from hospital to hospital to hospital, they each get their own patient identifiers that have to be managed. I remember looking at a really interesting study it was Maria Hernandez. It was a study done in Texas, in that they looked at one EHR and with patient identifier for Maria Hernandez, and there was something 72,000 patients with the same last name, and then 2,000 with the same first and last name. 63 had the same first name, last name, and date of birth, but they were 63 unique individual people. And so obviously you don't want to mix up patient records. Coming from Canada, one of our provinces, they actually even share the number for the first 6 months. So when someone gives birth, the baby has the same patient record number as the mother for 6 months. So there's a lot of problems, but there are solutions for that. And so if you're interested in it, the standards organization for IHE defines what we call a PICS. So this is the patient identity exchange, PDQ, which is the patient demographics query, which are standard ways to go about discovering and reconciling the patient information with what you've got locally. So there are solutions out there. IHE.net for that can certainly speak to the profiles and how you approach some of these problems that the big HIEs are leveraging.
Let me just add
one
other last thing on that. In my experience with the HIEs, the most aggressive one I've seen in terms of opening up and wanting to work with efforts is in New York. It's a project called Shiny. It's like State Health Information Network of New York. I know someone pretty close to that, so if somebody wants to get in touch with that individual, I can try to broker an intro, and it might be possible in short order to get access to the New York State data in some form. So I'll just offer that up.
And I actually wanted to add something to a comment that Damien made, and it was somewhat of a side comment, but I think it's a very important thing. We talked a lot about provider-facing technologies, but if we're talking about patient-facing technologies, there's a surprising lack of health literacy and health numeracy. A lot of patients either can't read or can't read to the level that they understand medical instructions, or their level of math competency doesn't enable them to understand dosing or scheduling, how to prepare for procedures. So if you're thinking about creating a patient-facing technology, and going forward this weekend, I would urge you to think about how you can make things as simple as possible in a way that it doesn't even require words even on a page. You can make it mostly visual so that a patient can understand how to take their medications the right way. Like, you'd be amazed at patients who take medications the wrong way and can really get into a lot of trouble because they're overdosing, they're like not removing patches and just keep adding like patches for medications all over their body. So that's a really important thing that I think that could be really impactful without necessarily being that complex that you can develop it over a weekend.
I can make one more comment on for what it's worth. There's, maybe for lack of a better term, opportunity by looking at the various diseases that people suffer. So things like allergies and carrying EpiPens. I saw a really neat study last week on that. How do we enable better treatment of someone who carries one of those pens? When does it expire? Is it with me? Does my child carry it with them? Do they have it? How do I track these sorts of things? But no matter what the disease, so celiac disease, someone who has gluten sensitive, someone who has multiple sclerosis, someone who has cancer, someone who has heart disease, COPD. There's lots of areas that could be explored for these particular niches and trying to solve the problems for that particular demographic, regardless of any of the other factors that they may be experiencing.
Yeah, and talk about the market potential, chronic, I don't know if somebody must know the numbers with chronic diseases and cost burden and the potential for changing health behaviors to influence the huge cost associated with chronic disease, especially in this country.
I think we have a question here in the book. Do you want to just stand up for us?
Thanks for spending the time. My question is, it might be oversimplification, but some of the problems that was mentioned in the panel, like syncing with patient applications and NTP and like dashboard, maybe it could be solved with like cloud, but cloud providers wasn't confident with that because what if the data get hacked? So my question is, what is your take on privacy versus this cloud syncing?
So just to repeat the question for everybody, the question was, how do you balance the benefit to having information in the cloud with privacy, especially in light of recent big corporate hacks? So.
And probably because we have probably a large collection of PHI data, and we take it very seriously. As a matter of fact, we don't put anything in the cloud. The only thing we'll consider cloud is basically our own internal mail system, is we've considered, but we have yet to embark on anything in the cloud of that nature. So with that being said, that's not saying that the usage of the cloud is not appropriate for different things. So we take very seriously the PHR data that we have. Matter of fact, we were considering even using cloud testing. We have all these devices that we have to support and test every time we put a release out, maybe every 2 months. So if you imagine the amount of testing that we have to do as every version of the operating system comes out and every different device type is there, and all the testing that we have to do to make sure our 2 million consumers, don't have problems. So we looked at a product. It was called Perfecta Mobile, and they had a cloud testing platform. And it's used by a lot of companies outside of the healthcare space. And they have a full lab that basically you can use virtually. It's got video cameras. It's got a full stack with devices, and they keep it up and current and all that kind of wonderful stuff. So, and we're very regimented in our scripting and testing, and to the point that every test that's proved, because the kind of data that we have, we have to capture the fact that the test did indeed work and stuff like that. So we made a decision. They gave a good proposal. It was actually a pretty decent from a cost perspective, as opposed to us building our own lab and having everything. So basically it got to our security and the people who did our risk analysis, and they said, in the test data that we really have, to be honest, we have QA versions of test data, but there's nothing like the real data. And we have to do testing on real data. Unfortunately, we replicate production data into QA. We try to obfuscate it, but even that wasn't good enough. So, from a payer perspective, from our perspective, cloud just doesn't work for us. And we to the point that even just the testing, which was just the UI, I was just looking at images, was not even allowed to be in the cloud.
Do you see that? Just a question for Ken. Do you see that changing moving forward?
There's different things that will move to the cloud. We have a lot of products that we use that don't have patient data, okay? So those things we will indeed look at. We have product and portfolio management tools. Like every large firm, we've got, maybe 200 projects that are going on every year in our portfolio. So those kinds of systems that keep that kind of data, certainly our payroll systems, our HR systems, those kinds of systems we are looking at aggressively. But the things that are related to patient kind of information or member information, we're not.
Yeah, I agree. It's definitely something to consider during, even this weekend during your sort of, especially the architecture, but also just the sort of product design phase, that if you're creating a provider, a clinician-facing app, that it is going to be very sort of expensive to put it in the cloud because of HIPAA, and for good reasons. So if you're thinking, I'm going to make the Uber for doctors and it's going to be, it's going to store the data in the cloud, no problem. As long as there's patient, data that providers use, then there's additional cost. But you could think of workarounds to that. For example, you could make software that a health system would install locally in their own data center, but that uses open standards. For example, there's a new standard called FHIR, F-H-I-R, by HL7, which is an open standard to take patient data, clinical data, and standardize it between health systems. So if you create a web interface or an app that takes that data and makes, clinician user interfaces, it could be very useful to different health systems. Rather than you could put it in the cloud maybe eventually, but you could also consider having them install it locally. But as far as the future, I think we are, moving to the cloud. It's just that health systems, and everyone really is a little slow to do that. So you have to think of it as, it has to be a really good product for it to sort of be provider-facing and exist in the cloud.
So sort of to add my own comments here, I think if you're thinking about using the cloud, you should always be thinking about what problems the cloud actually lets you solve. So the example that you gave when you asked the question was sort of this patient identifier. Well, to give an example, I think Penn has on the order of 100 different health IT systems just inside Penn itself. And all these health IT systems sort of interface with each other in various ways and exchange information. Now we could move all of those to a cloud. We could host them on Amazon EC2. But that doesn't really solve the problems that Penn actually encountered when there are essentially these various health IT systems within the same health system were not using the same patient identifying numbers. So this is sort of an interfacing issue at the software level, and the cloud won't solve that. Cloud can help you solve problems with scale, maybe, but in terms of the real tough problems in health IT, I don't necessarily see cloud as actually going to help you out much there.
I agree.
I would remind how important it is for patient confidentiality. I'm sure it goes without saying. If someone were to look at, my Fitbit, I've walked, 7,200 steps today, whoop-de-doo, I don't really care who knows that sort of information. But if someone were to come across information, it could destroy them. It could destroy their lives. It could destroy, what they do for occupations, what they do in their life. Coming from Canada, people take vacations, and we have insurance when we travel. Someone went to Hawaii, and they were 4 months pregnant, and they actually had to give birth in Hawaii. And when they were discharged, they had a bill for $1 million, and they were, making $70,000 a year. It was absolutely unheard of, but it was because there was some piece of information that was disclosed about them that the woman had some sort of kidney condition that was a pre-existing condition, completely ineligible for their insurance. So, in terms of what that information can do. For example, movie stars and people who have plastic surgery or sexual issues, like all kinds of different things. It's absolutely critical to protect that data. And so there are standards out there that can do that. I know cloud is a big topic. I deal with it worldwide in terms of what people are trying to do. Some countries are okay with it, some are not, some are slow to adopt. Some cloud vendors are HIPAA certified, so they claim that if you store data there, it is secured, but you have to consider information at rest and information in transit as well. So when you store information, is the database encrypted? When you retrieve that information, is the connection end-to-end, is it encrypted? Or can someone in the middle intercept that data? Can someone in the middle change that data? There is a lot to consider in terms of the security. One of my favorite articles on security is titled, "You're Terrible at Security," or something to that effect. And the point basically was, don't try to make security because you're terrible at it. Leverage what's out there, what libraries are available, and just let libraries do the security work for you. And the problem has been solved a million times over in all the other industries, banking and travel and email and everything else that's out there. So that there's a lot to consider. Depending on what your use case is, it may make sense, it may not. The last piece I'd say is that to consider in terms of storage and cloud, it is a lot of infrastructure to manage local storage at every single hospital, at every single doctor's office, to manage, if they need 10 terabytes or 100 terabytes of space, how do they grow, how do they manage? Cloud really offers a very effective way to just get storage off the shelf and not have to manage the staff to keep track of that, or the risk. Every week you hear of someone had their laptop stolen out of their car and 10,000 records were stored on that laptop. So there's a lot of information security issues that are at play.
So I'm going to build off of that and take a very contrary view to what you've heard from most other people, which is in healthcare the cloud is inevitable. And in every industry you have early adopters, you have innovators, you have early adopters, and you have sort of the mass market. And if you're expecting, all the blues to move to the cloud tomorrow, it's not going to happen. But 10, 15, 20 years from now, it will be a very different story. From the perspective of an investor and investing in startups regularly in healthcare, we would take a very hard look at any company that did not have a cloud-based solution for their solution in healthcare. Like if you're proposing on-premises delivery of your solution, that's a big red flag for us. And it's not to say that you're not going to be able, Penn may be a difficult customer to get. IBC may be a difficult customer to get unless you give them on-premises today. But there are other people who are already doing it. Even Penn and big institutions in the medical imaging space, for example, are very comfortable storing PHI and their data with secure providers off-site in their own clouds. Amazon, for example, has a fantastic approach and has put a lot of time into having a HIPAA-compliant cloud. Is it more expensive? Yes, you have to have dedicated instances. You have to work with them. But I know that, for example, at Penn, there are streamlined ways of getting your new application into Penn if you're using Amazon, because Amazon has been tested at some level by the powers that be as being secure enough, whatever that may mean. So I would not shy away. My view is I would not shy away from using the cloud for your solution. And it's not about necessarily solving the problem, although you're right in terms of the storage solution, it gives you scale. More importantly, if this is going to be a real product and a real company, you have to think about how that's going to scale. And the old way of doing business with installed software on site just doesn't work and is just unacceptable. So the world has to catch up a bit, but I wouldn't develop your new solution based on the old way of doing things. One person's perspective. It's a perfect example of like blowing up health insurance and doing it from scratch without the legacy stuff to weigh you down. So absolutely, kudos.
So I had a question for the panel that's a follow-up from Dr. Patel's talk, and so a lot of the concerns that we've talked about in terms of security and getting into the ecosystem and understanding the domain of the clinical system, there's an exciting additional avenue, which is the mobile phone, which can collect a lot of passive information. And I wondered if, both for the audience to sort of think about this and then for the panel, My question is, what sorts of things can we build as patients where typically the data has all been owned by payers and providers, but the majority of valuable health information, for example, when a doctor takes a history, is all about what's going on outside the hospital or what's going on before the doctor visit, which I think is kind of what Dr. Patel was talking about in terms of leveraging wearables. We have Muse here. MSEd is working with Oscar in the back. So what ways what sorts of data streams could we start thinking about collecting that don't really have any of these issues? There's no legacy partnering, there's no sort of entrenched partners or people with a vested interest in things going more slowly.
Well, there is this term e-patient, which refers to health without clinicians, and for example, patientslikeme.com. There have drawbacks and advantages to various systems. Well, even Zombies Run, the app I mentioned earlier, is an example of that, where it's not like it wouldn't be called connected health with your providers, but it's still a health app. It's a very grassroots type approach. You're competing against other users on the system. So you can use, I think there's a lot of opportunity to use sensors and do sort of a peer-to-peer type health platform.
One of the things along those lines is the area of what I'll call gamification, and essentially that's something that how do you get people to change their behavior, right? In terms of if you look at, there's all kinds of applications like MyFitnessPal is one of my favorite ones. It does a really good job of capturing whatever you eat, all the breakdowns of the foods, and are you meeting your goals and that kind of thing. And we partner actually with other companies that provide some of those applications as well. But having it such that that information that you capture in those applications has some meaning. Is I think if you could leverage them or find a way of basically providing some more incentive other than certainly if you want to lose weight and all that kind of stuff like a lot of us need to, you have to have a will and want to do it, right? And gamification is one thing that we've been looking into. We haven't really done anything yet. We had an early app that we developed that was helpful in terms of pedometer kind of stuff. It's long since passed. There's better ones out there today in the app stores these days. But if you had something from a gamification standard kind of thing where what we've looked into is again trying to look and figure out how people can change behaviors. It's a lot of it has to do with teams and peer pressures and social groups. And if you could come up with some kind of an app, right, that would kind of leverage the kinds of, whether it's MyFitnessPal data or the Fitbit kind of data or that kind of thing, where you could tie it into some social kind of thing, perhaps tied in with Facebook or Twitter or one of those things, where it's kind of like this peer thing. I mean, there's a whole segment, as we all know, that people just love to play games online and the 3D thing and the whole bit with that segment. But if you could take it down to the populace, the general JQ public that all have these needs to improve their health, right? Both from eating habits and exercising more and that kind of thing. And so gamification is one thing we haven't done a lot with ourselves yet. But we have a couple pilot things that we're doing that's more about educating some of the lower preschool and grammar school kids in terms of the right foods to eat, making a game out of that. But it only addresses a small microcosm of the problem. So if you could come up with something in an app this week, I think that's a perfect thing. That you could kind of, if you appear kind of thing, you play across anywhere in the country, you connect. There's a whole segment, I think.
I think it's really interesting when you're able to and it may sound a little bit cliche, but you take data and turn it into knowledge. Then you can take knowledge and turn it into understanding. There is a lot of data sets that are out there that the government provides, that other providers that are just out there that you can use, and APIs that you can use from NIMH and the Biontology Center. There's a whole bunch of different data sets. And to be able to take those things and merge them into data that consumers are already collecting can unlock some pretty powerful messages. One at a hackathon I participated in about a year and a half ago, I had taken data from a weight tracking website, so it comes off a scale and records it up on the cloud. But actually take that information and merge it in with my Facebook, and actually it'll grab all the photos that were tagged with me, and I can see on a timeline, here's where I was here, and here's where I am now, and how I'm doing. Just to be able to provide that into the infographics so that I can consume, in the 5 minutes while I'm on the bus. Say, oh, well, that's really interesting, and actually help me to alter the behaviors that I already have. So.
So I think we have time for about one or two more questions. To be more. Give some more time. Any other questions? Last call.
Yeah, sure, absolutely.
So just repeat the questions for everyone who didn't hear it. So it seems like there's a lot of low-hanging fruit, and the question was, and low-hanging fruit in terms of problems that are seen in the hospital and with patient care, and that solutions may even seem trivial, and why aren't these being solved by engineers or companies?
So the short answer is the only thing that's stopping in the way is you quitting whatever you're doing and working on it and solving it. But the real answer is a little more complicated than that. It's never the technology. There are technical solutions. They're going to be obvious to anyone who's technical and sees it, and you can kind of see the whole path to what it needs to look like, whether you're a designer, engineer, whatever. So creating that is one thing, and you can get that done in a week, a month, whatever you spend. But if you're going to turn it into an actual product, and an actual company that delivers that at scale and solves the problem in the world, you got to figure out, is there a business there or not? And that's where things break down. It kind of goes back to my earlier talk, which is misaligned incentives. You have a solution being used by doctors. You ask the doctors to pay. They'll say, I'm not paying for that. The insurance company's got to pay. And then you go talk to your friends at the Blues, and they say, I'm not paying for that. I don't get the benefit of that. The patient should pay. You talk to the patient, that's why I have insurance. So everybody's pointing fingers. And this will happen throughout healthcare. The incentives are often not aligned. And so the bigger challenge isn't the technical one. It's figuring out who's the customer, maybe not the user, whose problem are you solving economically that has skin in the game and is willing to pay something of value for the value you're creating for them. And that you're probably not going to solve that in a weekend, but that's worth thinking about. And if you're serious about solving this problem in the world, you're ultimately going to have to crack that nut for whatever it is you're doing.
Maybe one rule of thumb is talking about improving something that clinicians use is not, is this, I know a solution that's more elegant in terms of engineering, or it creates more efficiency, or it saves the user's time. Not those aren't enough. You have to create something that solves a real problem that people, that's costing the health system money, that's costing patients to really have bad outcomes that are identified as real problems. I'm just kind of saying the same thing, but just in different terms.
All about painkillers and antibiotics. Really needs to get pain and solve that pain. And for a doctor, maybe it's simple as I can go home sooner. They may not have signing authority for the check, but if enough of them care about that, they'll lean on the CFO maybe or Penn's department. It has to be a real problem.
Thank you so much for spending the afternoon with us. Thank you to the audience. We're going to have some refreshments in the back, and the panelists are going to stick around. I encourage you to meet people who you have next for. devices on first floor of town for checkout after the kickoff. And then the user's going to host a Google Hangout for people who are using it to teach you about their API and their SDK. And then additional sort of updates and things regarding health will come via our Twitter hashtag PennApps Health. And thank you so much for coming, and join me in giving a great round of applause for our panel.
You took it very
Chick, nice to meet you. Hi. You talk about the problem about I mean, what are some of the we actually here in Seattle, and like it's kind of really hard to actually verify with like over the weekend.
We didn't have a chance. We got started like 30 minutes ago. We didn't have a chance to like listen to the entire talk.
So what are your suggestions?
So I guess you were talking about game applications.
Like especially for hackathons.
And so we were thinking of making this application, which was kind of like
kind of basically on like
trying to
user
get people to
validation stuff because it's really hard to do.
stuff like that.
Like hospitals not like
Do on blocks and go on board.
ask questions.
Physical activity type stuff. Where basically like you like find people like that are local who are also trying to do the same thing.
That's actually a really good idea.
And like connect them up and stuff like that.
Yeah, it's kind of like a social thing.
Yeah. So also wait, what company?
I'm with Independent.
Okay.
Are you guys going to stick around over the hackathon?
I mean,
Yeah, we're
Nice.
So we basically provide, members that are basically use our apps, and they basically, we try and do things to make them healthy, right? And we are providing.
So you're working at the there's a Penn Medicine, like School of Medicine.
Companies that basically fit big data and will, provide more of a healthcare profile, a wellness profile, across the board for them. But we haven't found one that really does it.
It's really like I'm studying at University of Washington.
I mean, there's ones
They
out
have like
there
the
that
similar stuff as well. But I'm not sure. I need to learn more about this.
So I think that's a great idea.
All right, thanks, Damien.
Because it gets people out walking, they make friends. People when they make friends and things like help their health and longevity. They continue. I think it's a good idea. You don't need a lot of external data.
Yeah. So that was another thing that we were wondering about, kind of like, so there's like all these
what data you could use tonight at 9 with the technical team. Okay.
Like what can be done. Like I mean, right off the top, like maybe use it like some like sort of machine learning, like to diagnose, like based on like what people do.
On the first floor.
Yeah, I mean, we're a payer, so we're not the provider side. We don't get
to use one of these. So if you have a
because I looked at the
a lot of people are trying to he was like, what doctor do I use? What provider? That's one that's going to, be the least amount of out-of-pocket cost, but get you the better quality of service. So that is the big thrust in healthcare. Is cost transparency. So ones that basically say, help me find a doctor, basically, tell me about the quality of your outcomes, and basically, what did you cost me in my pocket, like to be put the box in. That's a major, I mean, some companies that are actually listen in that area, but we're looking for we have some stuff that we've done based on, data warehouse whole claim data, in terms of what the average cost is, procedure codes, so we also do put that together with quality to start, and more importantly, outcomes, which are not
And I don't And my guys, the two guys there on the table, they'll be here today. So we have something. We also have utilization data. So if you see us, blue cameras back there, engineering quality. Good luck. Thanks.
Both. I think it's like, I actually thought, so I went to MSEd for like housing players, so they're actually recruiting for like software engineers. But I was like, okay, I've never heard of that business. I feel like it's like 10 years ago. So I think we just got out of like lifetime experience. So I called them up because they like said, oh, you can request it. And I was like, okay, I kind of want to switch to it. So they're like really good, where they were like, we'll talk on the phone. But I feel like from what I gathered from her is that it was like this communication between like science and people, and then like that it was like has something done. So like their vision is that while we're working would actually exist, and like I feel walking around so that in my that's like a round it's like 3 rounds in my yeah. There's like a generation gap on us. Yeah, so I would love to get more involved. I think like I'm waiting to hear from her kind of she was like she's asking about like potentially sharing like positions. Just because I think right now she feels like she's just walking on the side and she's like that whole type of thing. But like how to make something so like if it doesn't work out with her, like is there a good way that we can like I can get plugged in with projects that are still happening and like motivation. It's still like this. Like I don't know where that is. Like I don't know. Yeah, like it could be anything on the spectrum. So it's definitely my year out. It's kind of like up to what I want to do with it. So I know the Intermittent team like has that all available. So if I was doing the project, I could probably do it. They actually have like a very small amount that they can have. But personally, for me, it's more just like so I can do it more and kind of like learn more. Because I think right now it's like year out. And actually like learning possibly not very like innovative or like enough that like I'm considering how to do it, but right now like thinking about just applying for some jobs or like kind of like a project manager position where managing teams like so like that's where I am like so I was really no yeah I considered it I don't know actually sometimes I'm like I don't know if it's the best way to like explore what I want but it's hard I think it's like just part of my career so I considered so a lot of times, like at the sub, I would just be like calling the like CT office like over and over to see like if it's done, and then like having to find the nurse to like indicate a particular order being put in, like just like physically. So I think like having the texting, I don't know, because I've heard of there's like some barrier to using curator actually, but some of it's like slow or people actually have a smartphone. I think there's a smartphone, like not everyone carries it, it's more like on the benefit for it, but I've seen people use it.
Yeah, I haven't heard that. I mean, I know about like other nurses, but I haven't heard that, you know, many places, but I haven't, it's not like really about piloting.
Yeah. Yeah.